So hi, and thank you again to Dr. McClellan and Dr. White for doing the supplemental Q&A session for us. The November 8th training was very riveting. It was very impactful. I think a lot of the audience wanted to engage. And, you know, being as though we were on a Zoom webinar platform, it was kind of hard, but they had a lot of questions based on the material. So we're just going to take this time to touch on some of those questions. And again, I just want to thank you on behalf of the entire HRSA team in Westchester University for carving out the time to do this. So with that, the first question is for Dr. McClellan, and the question asker would like to hear about your experiences or thoughts around using the ACEs assessment with patients, and have you found it to be helpful?
That's a great question. I do find it helpful. Categorically, I find it helpful. But just as all screening tools in a clinical environment, you really need to make sure that one, you remember the history and the development of the tool. You know, ACEs was, as we spoke, you know, in our main session, ACEs as a screening tool historically and was developed in a very small segment of mainly individuals who identify as white, as Caucasian, large pools of information, but really we need to make sure that we can't really adopt it or adapt it and keep the tool whole, of course, but as clinicians, we need to understand that when the findings occur and that when we assess those findings, that we have to remember where the tool came from. And most of us don't do a lot of this trauma work in exactly the segment of the population that ACEs was historically derived from.
Thank you so much for that. And as a follow-up, how do you ensure that a patient's experience with trauma is taken into consideration during treatment or time spent in the medical setting?
I apologize, Fatima. Can you repeat that question? Sorry.
Sure, no problem. It says, how do you ensure that a patient's experience with trauma is taken into consideration during treatment or time spent in the medical setting?
Okay, another great question. So I think with the practice and the adoption of a trauma-informed care practice, we are always centering the patient. You know, it's just inherent in the model, which is what I personally as a clinician enjoy so much about is we are always checking in with the patient. We are always taking into consideration their cues on what is a safe space to them. So I think as long as you keep that in mind at all times and you center the patient in all of your interventions, discussions, and assessments, you're going to stay true to that, and the patient will always be informing you along the way, and you're adjusting along the way to make sure that they stay safe.
Very well said. Thank you. And so now for Dr. White, this is regarding trauma diagnoses in the school setting and how kids of color, particularly Black kids, are diagnosed as ADHD, and how IDEA does not recognize trauma, and more often than not, BioFit kids are identified as having emotional disturbances. What advice do you have for our school counselors who may recognize behavior as trauma, but the schools will see it as ED?
Thank you, Fatima. So I have a very long answer to that question in my mind. I'm trying to whittle it down as I'm thinking through it. And so first of all, you know, we have to honor that many of our school counselors didn't get all of the training that our mental health counselors receive to be licensed. And so I know, you know, studies show this, school counselors speak to this, that they oftentimes don't feel a lot of confidence when it comes to diagnosis. And I would presume that that lack of confidence could come into play when trying to advocate for students, particularly when they don't feel like they've been trained enough to speak to diagnosis and in different differing between diagnoses. And so the first thing I will say is I encourage school counselors beyond their degree to continue to get CEUs specified in trauma, right? In those things so they can feel more confident when they are advocating for students. Secondly, you know, central to our counseling identity, this is an ACA code of ethics, right? When we look at the multicultural social justice competencies, we know that advocacy is a part of our job. And so if counselors aren't advocating, then they're not fully fulfilling the job requirement, right? And so it's important that they get experience stretching their advocacy muscles. And so whether that is attending school board meetings or city council meetings, really getting involved in the community, they have to really stretch those advocacy muscles. Superintendents listen to parents, right? So parents have a lot of voice. And so if I would give advice outside the two things I already mentioned, I would say make sure you know your students' families and you partner with the families, because then you can say, you know what, this is happening. This is what I'm seeing. Let's develop a plan together to approach this, to address this. How can I support you to advocate for your child, nephew, cousin? You know, how can I support you in this advocacy? What do you want me to do on my end, right? And then making sure you, school counselors, are a part of those IEP meetings and not being quiet in those meetings. And so yes, there's a school psychologist who's trained in assessments, but making sure you say, you know, these assessments are biased, to what Dr. McClellan said earlier. These assessments are biased. And I know that, you know, things that look like ADHD can be trauma, particularly given the population that we're working with. Have we considered this? Have we first considered these things? Have we ruled these things out before we automatically throw this emotional disturbance diagnosis on kids? And there's something else I want to add to that. As someone who worked a lot in the school system, school psychologists, and this is just fact, tend to use ED, emotional disturbance, as a catch-all. So if they feel like a student isn't fitting nicely within the other categories, they automatically default to emotional disturbance. And so that's problematic in and of itself. And so that's something that I would encourage school counselors to advocate around as well.
Thank you, Dr. White. That is really great advice. And as a follow-up to that, another question is, what does their certificate in trauma allow you to do? And do you have any recommendations as to where would be the best place to go to get certified in trauma?
So I apologize, there's some noise behind me. So if you're hearing it, let me know. So there are many places that do trauma certifications. I'm actually certified in trauma-focused CBT, right? And so you can literally just make sure you go to an accredited institution to get a trauma certification. For counselors, you know, NBCC does a lot of training around trauma. And so that's the National Board for Certified Counselors. And so I would encourage folks to go to their website. I think it's just nbcc.org, and you can see the list of trainings that they have, but also I think it's called PEI, and I don't know what that stands for. They do some training and certifications in trauma as well, but then also for and I know that, you know, a lot of the folks who are on the call were social workers. And as a counselor, I know a lot of the counselor resources, but members of ACA get a free CEU each month, and you can even go back and get the CEU. And so you could go on the website to see which trauma classes or webinars or sessions they've done to get that additional, at least, knowledge, even if you're not getting a certification. And then there are schools, I don't know if Westchester does it, there are schools that have trauma courses. I know Drexel certainly has courses specifically around trauma. And so I would encourage students to seek those out and take them, even if it's not in their department. If they have space for an elective or can do some continuing education and take a course in trauma, that would be awesome as well.
Okay, great. Thank you for that great information. And on the topic of trauma, Dr. McClellan, this is for you. And it says, working in a hospital, what are other ways you utilize your background in trauma and work with clients as well as with colleagues?
So So full disclosure, I'm no longer working within the hospital. I haven't for many years, and so I'm not sure how many nurses kind of were in the audience, or clinicians who we think are often traditionally in the hospital. Many of us are not. Nurses are out in the community working in population health, public health quite a bit, and even more so with what's been happening to all of us in the last year and a half. But for those who in the audience who may be in the hospital working, I can tell you as I have the opportunity to educate nurses now who are getting ready maybe to pick a profession or a field in a hospital, and my history of working in the community that would often I would follow my patients into the hospital and sometimes engage there. And I think to Dr. White's point about advocacy being part of our job, we as nurses and public health clinicians also, that is our mantra as well. It's very much part of our job, not just to provide the care, but to advocate when patients, families, consumers of our services are needing that advocacy. So I think, the times that I remember, and I also try to prepare my students now who might be getting ready to go into the hospital, when I've needed to intervene, or even more specifically advocate, it was really always around advocacy for making sure that in a very medicalized clinical setting like a hospital or an institution, sometimes we forget, how folks present when they've been traumatized and they don't fit into these nice little, partitions that we would like patients to look like. And if we are, again, going back to that patient-centered approach, if we are centering our care, it doesn't really matter where it is. If it's in the community, if it's on the street, if it's in a shelter, or if it's in a hospital, we need to center our care. And if someone's been traumatized, that would of course include this model of trauma-informed care and meeting them where they are. And that often does not happen in the hospital or in institutions. So our job for advocacy has to even be more verbose.
Yes, absolutely. So thank you for that.
Mm-hmm.
And Dr. White, this is about the question asker previously worked in a high school with youth and used the resiliency C's that you discussed, and they now work with young adults and adults who are experiencing incarceration, both pre-release in the prison and post-release reentry. So they're curious about using these with the young adults who are age ranging from 18 to 24, and your thoughts about that.
And so, and I have, a nurse here to back me up here. And so, adolescence is seen to extend to the age of 24 by most measures. And so it's important, right? Fatema's like, really? Yep. Right, because we talk about brain development and when our brains really reach maturation or most maturation. And so, and what that really means is that when do we start reasoning more than we act off of our impulses? Right. And so it's shown that really up until the time that we're at 24, we're still very, reactive and not stretching our reasoning muscles as much. So the C's model for resiliency for positive youth development is completely appropriate for that age group. Having had, substantial experience working within the prison system with that very population and even older, I'm one of the people, and this is just a theory, I'm one of the people that really believe that sometimes people, I don't want to necessarily say get stuck, but typically the age at when someone gets arrested, there's something that happens where if they're incarcerated beyond that, that they stay that age, it seems, maturity wise or emotionally wise, right? And so you want to be able to meet any of your clients where they are. What does it look like to foster confidence in incarcerated young adults? What is it like to foster competence, right? To reinforce and affirm folks' value, even though they're behind bars, or even though society around them is telling them that their future is now very limited. And so it's important to help to highlight and amplify the positives to validate their situations and experiences, right? To talk through their choices and not demonize them or condemn them, and then really help them to develop a plan for their release, right? And so does that mean partnering with family members, with pastors, with coaches, people who were mentors to them or people that they trust and value? Maybe it means that. Does it mean helping them with creative writing? Maybe it means that as well. Does it mean, give them some leadership responsibility even within the prison system? Maybe it means that as well, those bars really don't have to confine what you're able to do when it comes to those C's. So absolutely it's appropriate for that population.
Thank you. And it's really good to know that these concepts could be used across different populations and settings. Again, thank you for that. And again, this question is for you, Dr. White. And it says, can you talk more about fostering resilience as a placeholder for justice? Do you mean that people who are resilient are less likely to surrender to injustice and more likely to work toward and expect and demand justice?
Okay, that's the question. So I want to say yes. So Dr. McClellan and I have had these conversations, and I think she was the first one to say during our presentation that she sees resilience as a placeholder for justice. So let's talk about resilience. I have a very, I'm very reactive, very triggered by that word, as I think I said in the presentation, because resilience really means like your bounce back ability, right? How much can you take and still keep going and still keep pushing? And so when we speak to folks of color, particularly those in urban environments who live in under-resourced communities that are plagued by violence, who live under enormous amounts of oppression, what we're saying is, how much oppression can you take and keep moving forward? How many walls can you bump up against before you give up, right? And so when we are fostering resilience in folks, to some extent, we have to acknowledge that we are saying that we're teaching people how to cope with and accept their oppression, right? We're saying, listen, this is your life. This is what you're going to have to contend with. So you got to be strong enough to then deal with that circumstance. And we have to do a both and, right? So resilience is important. And I think that we don't have to foster it because the mere fact that these communities still exist have proven that they are already resilient, right? They're surviving. They're, in many cases, some folks are even thriving, but they're moving beyond basic needs. And so they're already resilient. I don't have to foster that. I would love to foster advocacy, right? How can I foster that? How can I foster equity? How can I, instead of looking to the community and say, listen, how can you be stronger? I can look to the systems and say, how can we make it so that people don't have to be so strong, right? So that people don't have to have all of this resilience. And interestingly, and I learned this years ago at a presentation that literally blew my mind, that and I might be saying this wrong, I'm not, in the medical field, but there are alleles that they have identified that are resilience genes, that we all have 2 alleles, either too short or too long, or 1 short and 1 long. And if you have 2 long, you have like the most resilience. If you have 1 long and 1 short, you have some resilience. If you have 2 short, it means you don't have a lot of resilience. And, surprise, surprise, Black folks most often have 2 long ones, right? And so what that means to me is that even our bodies, I think about evolution, even our bodies have had to make a change to deal with this oppression and to deal with this trauma. And so there's something happening physiologically, biologically to us that we're even holding in our bodies because of all of the oppression and trauma that we have to endure. And that was something that was necessary because of the oppression, but it doesn't have to be something that always exists if we are truly fostering advocacy and equity and justice, to Dr. McClellan's point. Did you want to add something to that, Dr. McClellan? Because I'm not, I didn't get any medical training, so.
Oh, well, and actually, I don't know that study, so you just taught me something very, yeah, absolutely. But it's so compelling. We'll have to talk. Ebony and I have great conversations, so we'll have to talk about that again. But yeah, of course, to Dr. White's point, we often, she and I enjoy these conversations. I thoroughly enjoy these conversations, and I think where to just go back to the person's question too, is that, this placeholder idea, to Dr. White's point, is it would be lovely to get away from always asking the communities that have been traumatized to ask them to continue their resilience. Excellent point also, Ebony, of course, is that, we don't really need to foster that, because they're there. It's happening. People survive and thrive, to her point, but let's not continue the conversation where we say, let's foster that, because then we're letting the oppressive policy makers, the way our system is set up, we're letting it off the hook, really. So let's stop, talking about fostering more of something that is absolutely occurring, or people wouldn't be able to get up every day, right? And do the things that they do. Let's make that a placeholder until we can fix, and only by advocacy, only by calling it out and having conversations like this one. Let's fix the problem, finally. Let's work towards that. Let's foster that, because obviously that's been very lacking. That needs the fostering.
Yes, I agree with both of you. Very powerful. Thank you for the distinction and the clarification. And speaking of genetics, that is a great segue into another question that we have. And this is for you both. And that question is, do you think the horror of slavery and the resultant trauma that Black people experience has become embedded in our genetic base?
So I love being a nurse practitioner, but I am not an expert in genetics. Dr. White just taught me something amazingly about alleles, and that. So I think, yeah, please, Dr. White, if you want to continue.
So I was silent because I have a lot to say about it, and I didn't
want
to take all of the time. So Dr. Joy DeGroy, she has a book, I believe it's called Post-Traumatic Slave Syndrome. And it talks about how that historical trauma is stored in our DNA, right? And so not only do we, like it's embedded in our genetic code, right? So we have this historical connection. I can't think of her name. There's this writer, oh my God, what is her name? And she writes a lot about history and bringing it to today's times. And I can't think of her name. I'll think of it before the end of the session, but how our history is inextricably tied to our present, right? And I would say that, slavery is not just embedded in our bodies and our genetic code, right? It's embedded in the very fabric of our country and our history and our policies, right? It's embedded there because a lot of those things continue to persist. The stratification and the oppression as a result continues to persist. And so it was got to talk about Dr. King. It was Dr. King that talked about the myth of meritocracy and how Black folks are the only folks who, number one, were brought to this country, right? But who also weren't given land, they weren't given money like the European immigrants were given and Asian immigrants were given, right? And so these other ethnic populations were able to come over and create some wealth and keep that wealth within their communities, and Black folks were given nothing. And even once slavery ended, and then when it really ended, he talks about how it was freedom to famine. It wasn't freedom to produce or to succeed or to get land. Like it was, okay, now you're free, but you have nothing. And so what do you do then? How do you survive then? And then slavery continues to take on different forms, right? And so I truly believe that we're not post-slavery, right? Slavery just looks different than it looked, on a plantation, right? It went from, legislative slavery to using the incarceration system as slavery, right? Which really went from, oh, I'm going to lie and say this person stole from me and he has to work on my field for 30 years to pay off his debt. And so that slavery really continued to doing unfair incarceration and policing practices in Black communities and against Black folks, right? Why is it that I could have, thousands of dollars worth of heroin on me, and then have an ounce of crack and get more time and have to do 85% of my time for that, right? Like what is going on here is very racialized. So to answer the question, yes, it is in our system because, Black folks are a collectivistic community. And so, and I know that there are some, white folks and other folks who have this response too, but I was thinking about Tamir Rice just this morning because I'm waiting for this Kyle Rittenhouse verdict to come through, and the folks who murdered Ahmaud Arbery, they're on trial right now too. So all of that is stored in my body, right? And what am I feeling? I'm feeling a lack of safety. I'm feeling some sadness. I'm feeling hypervigilant, right? I'm feeling on edge because inside of me, I'm hoping that justice is served, but another piece of me remembers my history. And I don't just remember it within my mind, I remember it in my body. And so all of these things are happening to me. I wonder how a 12-year-old Black boy could be murdered in less than 3 seconds. And Kyle Rittenhouse could walk through the streets of Kenosha with an AR-15 and be given water by the police, right? Mm-hmm. And so those things, it brings up very vivid images in my mind. I recall stories of my mother and grandmother and great-grandmother and, movies and things of my ancestors, right? So a piece of me remembers that. And speaking of, there was a question earlier talked about to Dr. McClellan, about how do you consider trauma or include trauma? I can't remember the exact wording of it when you're working in a medical field where people are getting medical treatment, right? Like I think about how when my grandma went to the hospital one time, the doctor just started touching her and didn't ask permission. Right? And seeing how she tensed up, but also seeing that she didn't feel like she could advocate for herself. That if I say something, are they going to treat me badly? Mm-hmm. Right? And so we have to really think about how our history influences how we seek how folks seek services. And then it should influence, seeing someone and being able to see their history when they're sitting there and not just an individual, then that should influence how you provide services. As well. I told you I was going to be long-winded, and I'm going to find that book as you go to the next question.
Thank you so much. As a Black woman waiting for these verdicts as well, very relatable experiences. So trust me, I understand. I'm sure a lot of our people are right there with us. So thank you for that. And this last question also speaks to theory, and it speaks to your point, Dr. White, about how you mentioned critical race theory has become a hot button topic. And the question is about how many minority youth grow up in the suburbs. They're faced with similar identity issues and struggles. So how might we approach addressing these issues in communities where the constructive language introduced at November 8th training might be considered offensive?
Yeah, so the author's name is Octavia Butler. The name of the book is Kindred that I was thinking of. And this is a conversation that you and I have had too, Kim. I don't think you could call yourself an ally, an advocate, or a co-conspirator if you're not willing to lose something, right? If you're not taking a risk, then that's not advocacy. If advocacy is easy and you ain't losing nothing, then it's, you're not advocating, you just, talking. And so we have to stand firm in our beliefs, and we have to really show people that this is not just words. This is not simply about curriculum. It's not simply, about, being Democrat or Republican, white or Black. This is life and death, right? And what does it do to someone's identity to take English for 4 years in school and not have one writer who looks like them? What does it do? And I'm not just talking about the Black folks' identity, right? Because it's teaching white people too. It's teaching Asian people. It's teaching Latinx people about our society. What does it say that we have a class called American History and we don't talk about any Black people? And we don't talk about any indigenous people. Mm-hmm. Like, that's crazy to me. What does it mean that even, the languages that we allow in our schools for students to learn that none of them are African languages. Right? They're all European languages. And people might say, oh, they talk Spanish in my school, but that's from Spain. They're not teaching you Puerto Rican. They're not teaching you, you know what I mean? They're teaching you Spanish. Right? These things have meaning. They tell us how we're seen, and they tell other people how to see people, how to see us, how to see others as well, how to interact. You know, Pierce Carew, and I can't remember who the other authors were, who came up with the term microaggression. They were doing a study of the media, and this was in the 70s, showing how racism is promoted through media, and how that's very dangerous, because at that time they were saying we were ingesting about 10,000 commercials per day. Right. And they pulled out, I mean, this was a really landmark study. I think it was in 76 or 78. So I encourage people to read that. Right. They were the first person to talk about microaggressions. They talked about it in the media and how racism was promoted through the media. Right. About how put any child in front of 3 different dolls, any child, and they're going to pick the white doll. Like, that is something that if they're not learning, they're learning it somewhere, right? Or we look at all of the media. I'm preaching now. I hear myself. We look at how, you know, all of these news outlets keep interviewing all these white parents about how they don't want critical race theory. Not one news outlet has interviewed a Black parent about critical race theory in schools. Not one. You cannot find it, because it shows whose voice is valuable, whose voice has power. Right? And that's completely problematic. And so when we are in schools and we are getting resistance about teaching the truth, about teaching certain content, we take that resistance, you know, going back to resilience, right? We take that resistance because this resistance hopefully will lead to justice. Right? Because I made a decision that I'm not going to be complicit in a racist system. Right? And so, you know, I've made peace with whatever that consequence would be, but I understand, particularly as a woman of color, that there's a price to my soul that's worth more than the price to my paycheck or the price to my job. You know what I mean? And so that is really important to me. And it's so interesting because when I engage in conversations with people around critical race theory, they don't even know what it is. They don't even know what it is. And that's the thing that irritates me. If you read it and understood it and knew what it was and then said, okay, let's not do it, then I would be able to hear your point. But when I ask you, okay, what about critical race theory do you not like? And you can't even tell me. Yeah.
Yeah.
Did I answer the question?
Yes, you did. And you actually prompted me to think of a question, like thinking for Dr. McClellan, like in the higher education setting, how do you apply these concepts to you educating your students?
I'm thinking about that for a minute. Some of my next answers, my next words are going to sound a bit like what I've answered before, and I apologize for that. But I think, you know, in the courses that I'm so privileged to teach, inherent in that are, you know, it's population health. It's many times, and I'm kind of thinking and speaking at the same time, because I don't know if I've ever really dove into this, but I think it's a great thing to think about, is that, you know, if I'm truly involving my students, and to be honest, many of my students, the only course in their entire 5 years of nursing school where they actually dissect some of this information and self-reflect on how they position themselves and their positionality in this is my course. You know, so there's a problem there, obviously, right? But I'm happy that they are there, and many walk in to my course with a predetermined idea of what it's going to be. And as we start to mix it up, and this, I'm getting to your answer, to answering your question, I'm sorry, is when we start to mix up ideas and I start to, I try mentor them through this idea that it's really okay to be uncomfortable. In fact, it's probably where we need to go to start to tackle some of these really critical, difficult conversations, but ones that I personally can't let them leave nursing school without having. You know, so we need to speak about, you know, advocacy. We need to speak about co-conspiracy, moving past being an ally and really deciding where do you stand. So it's wonderful to go back to our organizations and our policies and what the nursing process says and say, this is what it means to be a nurse. But if it really means that you're going to give care for all and respect for all, then it better be for all. And we better talk about the social determinants of health and the system that we all work in that stops that, not just doesn't provide for it, but actually purposely stops that from happening for a large group of people that are humans, right? So, I mean, I think we need to talk about that. It goes back to what the ANA and what a lot of our nursing mentors have asked us to do, but really didn't give the tools to do it. So going back to your question, I think I push these envelopes. I make people feel uncomfortable, but I try to do it with a safe space for them as well, so that we can have these real conversations and get them ready to go out and be change agents, which I'm not so sure if we left everything nice and safe, I don't think it would occur.
Yes, I definitely agree. And again, I just want to thank you both for such an amazing conversation. Thank you for acting as resources. And I'm sure the audience will agree when I say this, like giving us these tools and concepts to go out and really advocate for these changes and truly be change agents. So again, on behalf of the entire HRSA team and the Westchester community, thank you so much for your time. It was truly a pleasure. And I'm just inspired. Just thank you so much.
Thank you.
Thank you.